background, since we are recording, why we wanted to create this, event. We've been doing a number of events, both physical and virtual, for many years. We have the Global Virtual Healthcare Summit. We have the AR webinar series here. We have physical events in Boston, Tokyo, Hyderabad, India, so in Japan, in India. We have physical events here in Boston and Cambridge, both on the healthcare side and life science, pharma, biotech, medical device. We have the Cambridge Pharma Leaders event series. That is focusing on decentralized clinical trials, DCTs, and related emerging technologies. So we wanted, to create a place where those who are using the technologies could share their real life experiences and real world applications, not just, theoretical, academic. There's a place for that as well. However, we wanted, those who are using this technologies to share with their colleagues, either locally or around the world. And, this, has gone, a long way to, overcoming barriers of adoption, change management, just understanding, where to apply these technologies, how they're actually used by doctors. Doctors want to see, and others in life science pharma, in the healthcare side, doctors want to see, how are these technologies, actually improving patient care delivery, improving outcomes. In other industries, that might be the return on investment or return on engagement. Here it's, how is that actually improving, not just a nice to have, but a, something that's a must have. And everyone's talking about AI and these technologies, but we have a lot of the executives from healthcare, hospitals, heads of hospitals, pharma executives saying, people are coming to me talking about AI, but, what does that mean? So we have a couple minutes, 2 minutes now. We have our speaker coming in, 1 minute, and then I will make introductions. Welcome, everyone. I may not have a chance to acknowledge everyone one-on-one. Welcome, Julia. We just have about 30 seconds, and then I will go ahead and introduce you and the Doctor Innovators who are here for this insightful dialogue between AI influencers and Doctor Innovators. I had a few minutes, so I was sharing the background. It will be on the video that we will share across social media networks, just kind of on the background and the why we do what we do, and how we do it. Okay, so let's get into it. And we're going to keep everybody right on time today. So we will begin by welcoming CEO Julia Komissarchik. Her background, she holds degrees in mathematics from UC Berkeley, in computer science from Cornell University, over 20 years experience in artificial intelligence, including machine learning, deep learning, natural language processing. Co-founded Glendor Inc., focusing on enabling worldwide access to multimodal medical big data while protecting patient privacy. Developed the Glendor PHI sanitizer for secure data de-identification directly at the source. Holds 10 US patents in AI and has significantly contributed to projects like the NLP-based Did You Mean functionality for Wikipedia Foundation. Glendor's clients include major hospitals, NIH, lab networks, and big pharma. Julia, please.
Oh, thank you very much for inviting me to this event. I'm looking forward to speaking here. Let me start sharing. So let me know once you see a big green blob.
Yes, we've got it.
Excellent. So today's topic is importance of empowering high volume data sharing while protecting
Julia,
patients' privacy.
I think, is anyone else getting reverb? We're getting feedback.
I do.
Is there, is that any way to correct that? Is everyone on mute?
David, I don't know what. Yes, Julia just was muted because there was two Julias.
David,
oh, okay. Sorry, Julia, could you unmute? I think I muted you.
Yep.
I leave it open. I'll just ask everyone to mute, and we'll have open questions later. Thank you, Julia. Sorry.
I don't know why there are two Julias, so now I guess it will be just one.
Maybe your digital twin.
Exactly. Well, that's a very interesting solution, and maybe we can talk about it, but perhaps next time, right? So, that's what I wanted to talk about. And first of all, I wanted to explain why I think this is such an important subject. What's happening out there right now. And it's a very disconcerting trend. So the doctors are overworked, and there are fewer and fewer doctors because the numbers are not necessarily increasing in terms of, for example, radiology. I can give you some stats later, but at the same time, the number of doctors is fewer and fewer. At the same time, the number of patients is increasing. We're talking about two major trends. One of them is the aging population, and another is the population that is ever growing. Different countries have different mix of these two trends, but all countries throughout the world are seeing this trend. And as a result, there is a risk of collapse of the healthcare system because there are fewer and fewer doctors and more demand on them. So let me talk about some of the interesting numbers. And I'll look at it from the radiology point of view, but we're seeing the similar trends in other professions. For example, NHS England data says that between 2020 and 2022, the median age at which a clinical radiologist retired dropped from 58 to 51. At the same time, when there was when there was a survey of 15,000 physicians among approximately 600 radiologists who responded, 45% said that they're facing burnout and depression. So, I can go on. I have quite a few of those numbers like that. And from the, oops, jumped too fast. From the, when we're looking at the point of view from the size of population, for example, WHO reports that the world's population aged over 60 years will nearly double from 12 to 22% between 2015 and 2050. And for anybody who is interested, I can send you many more, much more data like this. So what we're seeing is the following: the number of doctors is even or maybe even decreasing, and the population and demand to the healthcare system is increasing. So we have to do something. One of the options, one of the solutions is possibly AI, because everybody's talking about it. This is something that everybody is, well, enamored with, and rightfully or wrongfully so. So from the rightfully so point of view, it's one of the interesting things that is happening right now, and we're seeing it as consumers through ChatGPT, OpenAI approaches, is so-called self-supervised learning. It's why don't I mention that a little bit later? But right now, what I wanted to talk about is where that in AI itself, even though we're seeing a lot of interesting developments outside of the healthcare, in healthcare itself, the development is still quite slow. And one of the main reasons, there are two contributors to best model training. One of them, well, three. One of them is people who come up with ideas, but two non-human contributors. One of them is hardware, which is available, and the other one is the medical data, which is available. Because without the medical data, without the diverse medical data for AI model training, the models are not robust, they're non-generalizable, and they're biased. Once again, I'm saying something that sort of stating the obvious, right? But why would we even want to use AI if we're discussing that it's non-generalizable and biased? It's because if we build large AI models, if we are in position to do this, then we can make healthcare sustainable for the patients. We're not talking about replacing any doctors. It's augmentation. It's taking off the heavy load and less creative load from the doctors. Sorry. And but one of the things which will require for AI models to be anywhere near humans is access to large volume of data. Okay. So what are we talking about when we're talking about AI? Because AI is a lot of things. You know, AI has been around for a while, and the joke that I was taught when I was just starting is that if you know what, AI, if you don't know how to solve a problem, the minute you know how to solve the problem, it becomes mathematics. So ChatGPT and other LLMs or so-called self-supervising models have proven themselves with quite a few applications. One of the best things about it is that those self-supervised learning, hence the name, do not require so-called ground truth, meaning somebody to, let's say, go back to the X-rays or radiology, somebody marking the radiologist report with I'm sorry, X-ray image. It's 6 a.m., so apologies, guys. X-ray image with details in terms of what the, let's say, professional doctors see. That will be ground truth, and then this information will be provided to the AI model for training. With self-supervised models, it is not required, which is actually a very arduous task. So, but the downside of this is that it cannot be trained without vast amounts of data. And by vast, I mean large volume. It's not hundreds, it's not thousands, millions of data points, millions and billions. So, but the good news is that if we look at all the data that is available and generated by the healthcare, 30% of it is medical data. So we have lots of it. At the same time, once the data is available, we can use it for AI models. However, one of the things to keep in mind is another study where it shows that 97% of all medical data goes directly to archive, and once generated is never looked at. So we have we have access to vast amount of data. It's just that we have to get provide to the AI models and AI model developers this data. And with that, with the generative AI, with self-supervised learning, we actually stand a chance of creating models that will be not just toys, but real models that can be used, like some of the models that are already being used. And we need more of those, okay? And so what should we do with those 30% of all data? One of the challenges is that for decades, medical data was stored in silos. Each hospital kept their patients' data in their own system, right? And it became, it's actually quite challenging if you're relocating from one state to another to even transfer the data from one hospital to another. And the other challenge with medical data, it's multimodal. It's not just medical reports. It will be medical images like X-rays, MRIs, ultrasounds. It will be videos, photos, for example, for dermatology, voice recordings, for etc. So what I would like to invite everybody to imagine is what will happen if we create vast medical data repositories, so-called data lakes, with data from hundreds or even thousands of hospitals, labs, and clinics. and then make this data available to the universities, to AI companies, to individual researchers and developers. By empowering this talent worldwide, we would be able to build AI models that can provide multiple breakthroughs and tectonic, in my opinion, change in healthcare. So let's take a look. Yeah, one can think of it as a data democratization process. So let's take a look at the medical data flow. This is oversimplified, right? But on a high level, what we're talking about is the following. We have patients who come for doctor visits, labs, get one of those IoT devices, right? We have data custodians, and that could be, for example, hospitals or a lab where that test was, or an IoT company that works with this, provided and works with this device. Then we have data aggregators like data lakes. So for example, it could be commercial data lakes, non-commercial data lakes. It could be government that also collects data from multiple hospitals and multiple labs countrywide. And then we have data users, so data consumers. Those would be research organizations, AI companies, pharmaceuticals, individual researchers and developers. So that's the medical data flow on a high level. However, and it looks really nice, right? Let's go from patient to data custodians to data aggregators, and then give access to this data to the data users. So that's the great part. But I encourage people to think about privacy, because unlike, let's say, ChatGPT, which was trained on websites, publicly available websites, when we're talking about medical data, we're not talking about bits and bytes. It's actually somebody's highly sensitive, highly private medical record. That's why it's very important to de-identify this information before it's shared with anybody. Before it leaves patient or data custodian, we have to make sure that it's de-identified. What do I mean by de-identification? Well, there are several laws. Different countries have different laws. Like in the US, there's HIPAA. In Europe, there's GDPR. There are other countries have other laws that are similar one way or another. But the whole idea is that one has to make sure that the information that is medical data that is provided cannot be linked back to the patient. That means that the information like patient's name, patient's date of birth, patient's address, doctor's address and name, and other information has to be removed before this data is shared. Good news is for most use cases, one doesn't need to know the name of the patient in order to leverage the data in AI training. So let me give you a couple of examples, and that's just scratching the surface. So for example, when it comes to medical images, there are two types of data, so-called burnt in. And as the name implies, it's the information that was burned into the image at the time the image was created. So in this case, we will have name of the patient, date of birth, date of the exam, which will be stamped into the image. There could be some other information, like extremely useful information that will be needed downstream, but there will be also private information. So when we're talking about de-identification, this information like name, date of birth, and study has to be removed from the image so that it cannot be recovered from this image. So in this case, it's whited out. The other part of the, for example, images, and usually when we're talking about images, we're talking about DICOMs, but there's also OCT formats and quite a few others, but DICOM is one of the most common. The other part is so-called meta tags. Those are also extremely important for research. They're extremely important when you're trying to identify, work with the record as a treating physician. But when it comes to sharing it with AI models, this information has to be de-identified. And meta tags could be, patient's name, study date, etc. But it also could be some ambiguous ones like study description, which can have a lot of sensitive information inadvertently put into it. And then another example, just to show you some examples that are not medical images, let's look at photos or videos. So here we have a surgery, colonoscopy to be exact. And remember, we have to make sure that the whatever data we're sharing is not traced back to the to the patient. So in this case, the faces of physicians, faces of the patients, any kind of tags on the patient or the doctors, any kind of background texts, all those will become sensitive and need to be de-identified, or in this case, blurred. Okay. So what I would say is, if we're going back to the medical data flow, it looks great, but let's make sure that before data leaves data custodian, it's de-identified. Because we have to, we need to make sure that we empower data sharing, but also we need to make sure that we protect patients' privacy. Because it's one of those things. Once the data is shared, there is no way to undelete it from the web, dark or otherwise. So what I would like to to call a call to action. So AI can dramatically, I hope I convinced you that AI can dramatically improve the current situation in the healthcare system. And full automatic self-supervised machine learning, which doesn't require time-consuming and labor-intensive manual labeling, is highly ground truth, is highly promising, but requires vast amounts of data. And huge data lakes of de-identified multimodal medical data accessible to any researcher or a developer in the world are essential. And major efforts should be placed in building multimodal medical data lakes. So, so that's what I wanted to talk about. And also one last slide, in case anybody wants to talk to me or have questions or ideas on data lakes, please reach out. And thank you.
Okay, thank you, Julia. Right on time. Yes, we will share that out. In the interest of time, we will move on because we have our Doctor Innovators here. It's called In-Depth Dialogue between CEO Julia and our 5 Doctor Innovators. We'll hold you at 6 minutes each. I know it's a very short amount of time. Dr. Mehraj, we will begin. Dr. Mehraj graduated from the Government Medical College in Srinagar, completed a master's in surgery and postdoc fellowship in colorectal surgery. Innovator, and I will just go right in. Dr. Mehraj, can you go right in with your questions? Everyone can read the background at the same time. Thank you very much.
Yeah. Thank you, Mr. David, for the kind words. And thank you, Ms. Julia, for an insightful talk. Really very helpful for all of us. So my query rather would be like, once we are sharing, like we all know data are the building blocks for any AI model. And but once we talk about the privacy of the patients, so what about the consent of the patient? See, once we share any data with any AI platform, so we have them in the huge repositories in our data banks or wherever, in whatever form we have, but we don't have the consent at that particular time. So anonymized or non-anonymized data. So what's the role of consent? If we don't have consent, how can we share? Because we know there are regulations like in India, and I believe in most of the countries, the patient's consent is important before we share any data. So how do we take care of that? So I have 2 more questions before, so you can ask, we can answer the first question, then we can go to this 2 more.
So that's actually a very important question. And how the consent is obtained varies from country to country, state to state, and hospital to hospital. So a lot of times it's a decision, it's a combination of the legal requirements as well as the hospital's decisions on how they want to handle this. From technology point of view, one of the ways that they can be handled is if you, let's say somebody wants to recall their consent, is to anonymize data, but still keep an ID of the data pieces that you're contributing, so that you can say which pieces you want to recover back from the data lake.
Okay.
Yeah, in some countries, the consent is opt-out. In some countries, the consent is opt-in. The difference is opt-out, meaning if I'm a patient, I have to explicitly say, I don't want my data to be shared, de-identified data to be shared. And opt-in is when my data can be shared only if I explicitly consented.
In case we don't have consent, then what? Can we share the data?
Well, that's a legal question, right? Yeah. It's definitely out of my lane.
And there we come up with one solution, which I think is about synthetic data. So how relevant do you think synthetic data vis-a-vis the actual data that we have in healthcare? So what's the role of synthetic data in healthcare?
Mm-hmm. Synthetic data can be useful in certain things. For example, if you want to train an advertisement system, right, where you just take ads or ad behavior from history, then rehash everything and rename everything. That's how the synthetic data is created, right? Synthetic data is based on real data, and then it's just rehashed so that hopefully you cannot trace it back to the original data. But there are holes. It's harder to do it's done algorithmically, of course, it's not by human, but how synthetic data is generated is you take a pool of existing data and then you generate synthetic data based on the patterns that you discovered in the original data. But here's the problem. First of all, it depends on how large is the pool that you started with, right? Because if the original pool was limited and biased, then your synthetic data will be limited and biased. Your synthetic data will be also limited and biased. There are also holes, right? I haven't yet seen an X-ray synthetically generated, which doesn't look like something from the movie Alien, right? We're getting there, but not yet. Remember how like synthetic data has, we all know about those 7, 8, 10 fingers on each hand, you know, that everybody is laughing about, or like teeth, which look like they're crocodile teeth because they're definitely like 50 or 100 teeth on an image. So it's still work in progress. And one of the things which I would encourage most is when you're doing synthetic data, make sure that the data you started with is as diverse as possible.
Okay, thank you. I think we will move on. Fascinating discussion. Very useful. Let's move on to Dr. Mashoud. Dr. Mashoud is Senior Registrar, Department of General Surgery at Obafemi Awolowo University Teaching Hospital in Nigeria. He holds an MB CHB from Obafemi as well, active member of West African College of Surgeons. So I'll let you go ahead and read the rest of Dr. Adeniyi's credentials. And please, Dr. Mashoud Adeniyi, continue with begin with your questions for Julia. Thank you.
Yeah, thank you very much, Dr. Professor David. Thank you also for the presentation. The question I would like to ask is about the usability of this. I think I've asked before about how, in terms of the ways it can be used, and you also mentioned that it can be used in telemedicine and all. So the question I would like to ask is, this model, will it work like the UDLIN in the Zoom meeting, whereby whichever kind of media you want to use to share those medical information, is it going to be like you attach it like an application, such a way that a lot of people can use it? I mean, it can be democratized, not necessarily being that it has to do with a kind of accompanying or something like that, that individual can use, maybe like download as an application. Then
the data?
No, this model.
Oh, I see. Yes, so there are different business models for AI in healthcare. Some of them where models are in open source, so then they can be used very highly democratized. Anybody can use those models. Some of them are created by for-profit corporations, so they will cost money. There are also companies that actually host a number of models. And one of the things that can be done is, for example, the data lake itself, not only hosting the data, but also hosting the models. But in terms of pricing, in terms of who can use what, that's very much similar to what's happening with software, where certain things are expensive. Some can be very expensive. Certain things are open source, but they're less supported. It's just it's very similar in that sense. AI or non-AI, in my opinion, it's the same behavior.
Thank you.
Sure. Thank you for the question. And there are several, actually for the AI models, there are several very good sites. For example, one that comes to mind is Hugging Face, which has quite a number of models. Yeah, the only, it's just, it requires more technical ability to be able to integrate them. But that's what I like about Hugging Face, quite a lot of models.
All right, thank you very much. I think that's all.
Thank you.
Okay, thank you. I think you're referring to the open source.
Yes.
Access.
But keep in mind that hasn't been vetted, right? This is not a third-party vetted, like FDA approved. So that's everything that I'm discussing has to be done. Like, you have to think of it from both sides, right? Whether or not we can access it, but also how good is it? Has it been validated, etc.
Okay, thank you very much. Thank you very much. Wonderful discussion. Let's move on to our third Doctor Innovator. Fiona will share screen. Dr. Omotola is Senior Registrar at Federal Medical Center in Nigeria, specializing in plastic, burns, reconstructive, aesthetic surgery, holds MBBS from the University of Jos and MPH from the Obafemi Alaola University. I will let you read impressive credentials of Dr. Omotola as she asks her question to Julia. Please, Dr. Omotola.
Okay, thank you, Professor.
Yes.
Good afternoon. So I have two questions as it relates to my field specifically. So the first question is, how do we use AI to analyze pictorial data taken over time, maybe from a particular patient, to monitor patient progress? How do we use it in decision making, considering that these pictures might be taken with different devices? So the camera quality might be different. I was talking about depth of color and all that. And it might be taken in different time of the day that would account for the differences in the lighting, and then maybe in different locations that could also impact on the picture quality. So how can AI help us to standardize these pictures so that despite these differences, a clinician can be better equipped to analyze these pictures taken over time and still arrive at a useful conclusion that can help manage patients, maybe not physically or maybe physically when they see after these pictures have been collected over time. So that's my first question. Do I go ahead with the second question, or can I wait for the?
Can I answer the first one?
Yeah,
you can answer. So that's actually, yeah, I agree with you. That's one of the biggest issues, right? That's why, for example, if one does bone scan, they encourage to come back to the same facility, because even with the same machine, but different settings, the results will be different. So that's actually extremely important. And also sometimes the quality is different if you're looking at data from the 90s versus something which was done yesterday, will also have different resolutions. So yes, it's a big deal and big problem. But that's the idea of these AI models, right? Is they're trying to mimic what we humans do, like what you do in yourself as a professional, by compensating for different quality and different types of images that we're taking over time. So that's why it's important to have representative sample of such historical data, not only the latest data. But there's also a whole field called image enhancing techniques. Once again, everything I said here, it has pros and cons. The pros is that one can enhance the image. The cons is if it's not done right, it will create artifacts that were not in the image to begin with, right? Sort of. The answer is twofold. One of them is AI image enhancing techniques, and another is representative sample so that the system can train and as close as possible mimic what we humans do when we compensate for old photographs versus new photographs. What was your second question?
Okay, thank you very much.
Sure.
The second question, I think you might have delved into it a little bit. I'll still go ahead to ask. I want to know how AI can contribute to research in 3D reconstruction. So we have 3D reconstruction here where a few models are used to create models of, say, for instance, the ear in ear reconstruction. So we get it from the market, and then maybe in theater we now surgically modify it down to the shape and size we want. But then doing it by hand, we found out that it's not always accurate, because we'd have to surgically use our human discretion to get the shape and size we want according to maybe the other ear that at that point is probably still present. So I'm wondering if AI can contribute to research that's 3D reconstruction, where using real-time data that is gathered, say when surgeons put in the values of their patients collected over time into a database, AI can now sieve this data to give us more accurate representation of different body parts according to age, sex, even race. Yes, I would want to know how AI can help us achieve this in the nearest future, so that we would not have to waste time as surgeons in theater, maybe wasting upwards of 2 hours trying to remodel an already modeled 3D reconstructed body part to get as close to what we want for the particular patient. And then with the attendant risk of actually spoiling that model on table or not getting the accurate shape and size we want because of human fallibility. So thank you.
Yeah, sure. And I would say that theoretically it can. The models need to be trained, but theoretically, AI models are designed for things like this. Having said that, at the end of the day, you mentioned human fallibility, but also I would say that humans, the doctors, they are the best placed to make certain decisions. So what I would think is that those AI models can be built. I don't see technical problems with doing this, right? Depending, we can go dive deeper into this, but I don't see technical difficulties with doing this. However, I would say that yes, but I would actually, frankly, from patient's point of view, encourage always to have a combination of AI and a human trained doctor.
Okay. Thank you.
Okay,
Yeah.
wonderful dialogue. Thank you. That's very interesting. I had not thought of a lot of that. That's really wonderful. Why we have this dialogue. Let's move on in the interest of.
David, sorry,
yes,
it's actually, if there is somebody in the audience who is training models, this is a very interesting use case. I can see a lot of doctors, patients, and countries that would be interested in this. So
yes,
thank
it
you,
is.
Doctor, for suggesting such a great use case.
Yeah, that is wonderful to think of. Thank you. Let's move on to Dr. Adnan Mohammed. He's respected general surgeon and assistant professor of surgery at Haramaya University, and in Ethiopia, directs quality improvement, clinical governance, I will let you in the audience read the rest of these impressive credentials as Dr. Mohammed asks his question to Julia. Thank you.
Thank you, Julia, and thank you, David. Can you hear me, everyone?
Yes, we
Yes,
can.
we can.
That's great. Currently, I'm in OR talking to you. Updating on my status, I'm currently a colorectal surgery fellow, and I've worked on quality improvement and patient safety. And what could be the place of AI in this field? That's my first question. And I would like to say that currently in the world, there are 3 types of countries according to AI. One of the countries are fastly working on AI. The others are, the least are no idea about AI. And there is a middle class that are working on AI. So some of the countries that are fastly working on AI are like US, India, and some European countries. Most of African countries are currently like or low and middle income countries are sleeping on, not working in regard to AI. So how can we bridge the gap? The other thing is there is you were talking about data. Data is the main thing to feed for this machine learning and artificial intelligence.
Yes.
There are huge obstacles and gaps. The quality of data, the raw data is not adequate for the. I think it might have a challenge for the AI, unless and otherwise it can get ample data. The data might be misleading. So how can we control these things and bridge the gap between these countries and ideas? That's my question. If you gave me, thank you for your interesting and ideas. Merci. Thank you.
Thank you. I think let me answer the first question. I think you had a question about whether or not there are AI models for wars. Is that correct? The first question that you had.
Pardon, please.
Yeah. I think the first question that I've heard was about whether or not there are AI models that work on triage and, for example, for emergency rooms. Is that correct, or am I, or did I mishear it?
This not like that. Not like that.
Okay, so for operating room in general, right? So in terms of whether or not there are AI models, yes, there are lots of AI models that are popping up everywhere. So there's, and also if there's a compelling use case, then I would encourage AI model developers to look into this. But your second question was very important, and that is whether or not how to collect this data. And yes, that's one of the big challenges, right? What is happening with the data collection is that we're getting more and more devices that, like X-ray devices that are this small, right? So there are more and more things that can be used to collect this data. But what I would encourage, especially for the countries where their data is not yet available, is to focus on that. Because the models that are developed, let's say in the US or Korea is another country which is doing a lot of AI and med development, AI healthcare development, those models can be retrained for another country. They might not be useful if, let's say, the data was a model was trained on US data. It might not even be applicable to some other countries, right? Because the population is different. And but if this model is already was successful in, let's say, US, then it can one can look into using the same model, but it has to be trained on the local data. That's why. Absolutely, for certain countries it will be more difficult, but what I'm seeing is that there's more and more data collection in the field, things that are collected with devices that don't necessarily require large infrastructure. So I'm hopeful, but yes, it's more difficult. And like with everything else, my recommendation, any data collection should be de-identified, no matter how it was collected.
Okay, we have about 3 more minutes, so feel free to follow up with a question or continue on your answer.
I don't know. Dr. Mohammed, any other questions for me?
No other question, Dr. Julia. It's interesting, and I appreciate your ideas. Helpful, very helpful and insightful. That's great.
No, you raised a very good question. Thank you.
Very insightful. And it's often a question. We are a global, diverse, inclusive organizations, and so often we work in a lot of underserved areas, as Dr. Adnan had mentioned. So this question comes up quite a bit about emerging technologies and how they can be accessed in underserved areas. So it's a challenging question, I know. Okay, let's move on. I think, Nate, we're about at time. Dr. Al-Hussona is a consultant ORL and head and neck surgeon with over 20 years experience, specializing in reconstruction and facial deformities, particularly cleft lip and palate. I know personally Dr. Al-Hussona is working on an innovation, which is a 3D scanning and 3D printing for the cleft palate. So he's been an innovator for many years. I'll let you read the rest of Dr. Al-Hussona's credentials. Please, Dr. Al-Hussona, with your question for Julia. Thank you.
Thanks, David. Thanks, our colleague, for this. How we can utilize this huge data lakes of artificial intelligence in aiding surgeons, especially my specialty, head and neck cancer patient, and tailoring a specific personalized plan of management for the best functional outcome and with oncologically sound results.
So like very much like with everything else, it's about understanding what you would like the AI to make a decision on, and also providing it with enough data to help it make those decisions. But one of the things that you and I discussed previously, right, is also how can we use those data lakes for surgeons for particular, not necessarily maybe even AI, directly using AI, how those data lakes can be leveraged, and that's in showing similar cases of similar medical cases that can be used for comparison. So that's another thing which we didn't necessarily discuss today because we were focusing on how to train AI models, but the availability of those data lakes, especially for rare diseases, especially for diseases where the number of examples is very limited, could be also used for this particular use case. So.
Thank you. My second question is about how can AI strengthen the relationship in between doctor and the patient. Especially, we tend to have telemedicine, telecommunication. This may, if one out of the healthcare providing system may think that it will omit the doctor as a leader for the healthcare.
Well, there's several things that can be done.
How we can aid that it will strengthen the relationship, not weaken it.
Right, and that's actually a very important thing. How to preserve the patient's trust in the doctor and the system they're using. And that's where actually a lot of work has been done, because it's much more similar to ChatGPT type of things. So any kind of support before the telehealth appointment, for example, questions like when is my appointment and other things that can be actually taken care of by AI and easily and without a lot of errors. So it's more of a being a supporter of the doctor in their interaction and their communications with the patient. That's in my opinion. Like, for example, even simple things like terminology definitions, right? When we're talking about cancer patients, negative is good and positive is bad, right? Which sort of is counterintuitive. When they say you have negative results, that means that your biopsy did not show any abnormalities. So explaining even that can be done with AI, because it's very counterintuitive.
Thank you.
Thank you, Dr. Hussona.
All right, wonderful discussion. Thank you. See, shall we move on to our next Dr. Innovator? And I put some notes in the chat. If you could, I'm sorry. Yes, we are at our Q&A for open. I put some notes in the chat. Please feel free to raise your hand, jump in, or type a question. And I'll read off a few questions. Jason, you have your hand up. I'll let you go ahead and jump in with your question, and then I will read the couple of questions in the chat after that. Thank you.
Okay. Thank you. Can you hear me properly?
Yes.
Okay. Yeah, my question to Dr. Julia. This is a very simple layman's question. So when you select the AI tools for this healthcare, as a strategy, how you can balance between the cost effectiveness of the healthcare and the choice of the AI tools you are going to implement in the routine treatment?
Understood. Yeah, and for everybody, the question was, how do you make a decision, balance between the cost effectiveness and the effectiveness of AI that you're using? And actually, Jason, I have to say, I'm not the right person to ask that, right? The right person to ask that would be a healthcare administrator. Because, for example, I personally, working in AI on a different area, what we work on is de-identification portion, right? Not necessarily diagnostic. That was our decision to focus on de-identification, because we're very passionate about patient protection in this whole process.
All right. Thank you. Thank you.
Okay. Thank you, Jason. Thank you, Julia. I will read a question that we had. Let me scroll up here. Anonymizing some of this from Dr. Ivukan Ogundele. Anonymizing some data may be difficult, e.g. data on facial abnormalities. How do we handle these for public use, especially from old data when consent was not obtained?
Yeah, and that's a good question, because one of the things is, for example, for any kind of facial images where the patient can be recognized. But it gets even trickier because, for example, if you're talking about brain MRI, the face can be reconstructed from the shape of the, brain MRI is like this slices, right? But the face can be reconstructed in this way. But the face can be reconstructed from those slices. So de-identification is a very challenging problem, right? And for certain things, it's even more problematic than for others, because, for example, for brain, one of the options is to so-called deskull it. And as the name says, you just basically remove the skull from the image. But actually that would impact things like biomarkers, because the data then doesn't show is not shown correctly. So yes, that's a very good question, and that's one of the challenges. Or how do you deal with dental records, where the dental record itself can be identifier?
Thank you, Julia.
So the answer is yes, it's a very challenging question.
It is. It is. We're adding more and more layers of complexity into these systems, and so many, looking at this from so many, as you mentioned, we have the legal, we have the ethical, we have the regulation, we have the technological, so many different aspects. We have one other question here. Apart from data anonymization, what is the place of encryption technologies in data sharing and privacy?
Well, that's extremely important. But the only thing is that if you want to share data, even if you encrypt it, the other side will be able to decrypt it, right? That's how it usually works. There are some use cases, but I'm not even going to go into that. And as a result, you're actually shared private information with a third party without identification. So the encryption is extremely important, but they go hand in hand. They don't replace one another.
Mm-hmm. Mm-hmm. And I know there's, of course, some newer emerging technologies that are being worked on, such as distributed ledger technology, DLT, blockchain, Web3, things like this, where maybe the data is not actually stored on the blockchain, but it will be a reference to where that data is stored, but then it's stored somewhere, and that could be potentially accessed. Could you speak?
Yeah, sure. So, but encryption means what I did is I took the package and encrypted it so that no stranger can open the lock, right? But if I need to use this data, in most cases, I have to unlock it. And then as a data user, I will have full access to the data. So that's what I'm saying is they go hand in hand. The data still needs to be de-identified. It's the question of how it's transferred. Let's say, David, you want to have some data of my patients, right? I don't have patients. I'm not the doctor, but let's say you do. Encryption will mean that I will take the data, put it into the nice package and lock the key, and then send you the package and then the key separately. But at the end of the day, you will be able to open the package. That's why I'm saying it's related, but it's not within the realm of, they go hand in hand.
Mm-hmm. Mm-hmm.
I wasn't sure whether you want to go into this. I'm happy to do this, but I'm not sure whether it will be within the scope.
Right. Maybe getting off track here. But does anyone have any other questions related to AI and again, real world applications, case studies?
Hi, David.
Yes, please, Dr.
Hi,
Leonard.
David. I have one. Thank you so much, Julia, for this amazing, insightful presentation. I would like to ask you if you have some ideas about the convergence about public health and private sector, like the project called Spark in Ontario, that they are sharing patient data to create a very insightful data lake for public and private sector. What do you think about the connection of these two?
I think it will be a good idea to have those data lakes, and I don't know what else to say. The answer is yes. Yes, that's an example of a data lake that will be very useful.
Okay, thank you.
One thing to think about is basically in government-based or private-based data lakes is how is everybody compensated, and whether or not the patient is compensated for the usage of that data. And that's something that I would be very interested to continue this discussion, because that needs to be solved for sure.
Okay, thank you so much. The compensation is a very important issue. Thank you so much.
Yeah, that's a good point as well. Patients controlling their data. We've had discussions on that as well. Being able to, when they choose, even be compensated to sell that data anonymously, privately, safely, securely, and anonymously, and how would they be compensated? What's the value of it? When they ask patients maybe in the US, they say, okay, it's worth $100,000. Everyone has a different value. Dr. Mehraj, please. I see your hand up. Please.
Yeah, just a curiosity, Julia. Like a practical thing, like there is so much diversification in the names itself. Like in one country, the names are like different, pronounced different, written differently, and in another West, East. So you see so many differences in the names itself. So how do your softwares pick up? How do you deal with this? That this is the name of a patient. How do you de-identify it?
Well, that's and you're absolutely right. That's one of the problems, right? And then it actually opens another can of worms called data normalization. As far as our software, how do you, as a person, if I show you a bunch of things, how would you identify that this is a patient's name, especially if the name is not typical for your patients? So you see that's how our software does it as well. There are certain indicators. There's quite a combination of factors that go into identifying that the name you've never seen is actually patient's name.
That's something that's inbuilt within the software.
Exactly. It's like, so AI, right? They're trying to mimic what we as humans do, right? How do we do this? That's the important question. But actually, you raised another. Your question raises another big item, and it's a separate discussion altogether, which is data normalization. Yes, absolutely. Different ways, different names that are used across the world. But it's actually even problematic when you're talking about even within the same hospital, because different people describe things differently. And that's a kind of worms called data normalization. And then we can talk about ontologies and other structures, but that's a challenge. But at the same time, there are certain things that are common, and one can work with those. David, I'm sorry, I'm trying not to go too far into that direction. So
no, that was great point. They say it's kind of a mirror to ourselves. We have to. That's very practical. We need to know how we do it before we can teach AI how to do it. So that's very good.
Not
point.
necessarily. Actually, quite funnily, certain things AI finds patterns faster than we do.
Okay, yeah, that's another.
So that's the thing, right? Every statement, there will be counterexamples as well as the examples of the statement.
A better way to do it, right? Like Go, the game Go, right? It kind of something emerging where they, it developed a different strategy for this game that nobody had ever even thought of. So
precisely.
Good point. Any other questions? Great discussion here. Any other? We have about 3 minutes. So let me see. Are there any other questions that I missed in the chat? Or anyone that wants to raise their hand or jump in? I leave it open. So if you want to jump in, you do have a question, that's fine as well.
And also, I have to say, if anybody on the audience has questions or wants to reach out, please reach out to me. If David, if it's okay with you, we can share my screen with my contact info, or you can share it.
Sure. Yeah, it's open.
Yeah, let me do this.
It's open. Well, thank you, everyone. Julia will share screen. Again, if you want to connect on LinkedIn with your colleagues here as well, feel free to share, and we will pass that on. Here's Julia's contact information. And if anyone has any questions, yes, feel free to send to us, send to Julia. We're happy to pass them on and continue the discussion. So I look forward to seeing everyone back next week for our, August 10th. Let me look here. Okay, yes, August 10th, same time. Look forward to seeing everyone. Let's just grab one, maybe a group photo here.
Yes.
Everyone, if you're somewhere where you can turn on your camera and wave or something, thumbs up, we'll grab a group photo if you can turn your camera on. I know we have a lot of the times the doctors are maybe in the hospital or something where they cannot turn the cameras on, but they always join us anyway. It's wonderful. Okay, Fiona will grab a screenshot here and we will share that. Thank you, everyone. Have a wonderful rest of your day, morning, afternoon, or evening.
Thank you. It's a pleasure to meet you.
Bye-bye.
Bye.
Thank you.
Bye-bye.
Bye.